This presentation is going to cover the exemplar of ARDS, which is acute respiratory distress syndrome under the concept of oxygenation. ARDS, or acute respiratory distress syndrome, is a common cause of respiratory failure. Remember, the function of the respiratory system is gas exchange. Failure of the respiratory system occurs when it's unable to do this. That is, for gas exchange to occur. And that's what we see in the picture here. We have two hemoglobin molecules carrying oxygen. And we need to have that oxygen picked up and carried by the hemoglobin molecules to the tissues where the oxygen is released. That must occur. That gas exchange, remember, occurs at the alveoli in the lungs. When that gas exchange does not occur, that is respiratory failure. Again, respiratory failure is not a disease, but rather a condition that occurs as a result of another disease of the lungs or diseases of other body systems. There are two types of respiratory failure. There's hypoxemic respiratory failure, and there is hypercapnia respiratory failure. ARDS, however, falls within the category of hypoxemic respiratory failure. There are many other causes of hypoxemic respiratory failure besides ARDS, and they are listed on this slide. You have probably at this point in their program covered all of these various common causes of hypoxemic respiratory failure. Remember the definition of hypoxemia, okay? That is different than hypoxia. Hypoxemia is when the percent of dissolved oxygen in the bloodstream is less than 80%. Okay, hypoxia is when the patient begins to show symptoms of low oxygen in the tissues, and that is a PaO2, or the percent of dissolved oxygen in the blood is less than 60%. Okay, so there are all these other conditions that, like ARDS, can cause hypoxemic respiratory failure, like pneumonia, toxic inhalation of smoke, pulmonary embolisms, and ventral septal defects, pulmonary edema, and cardiogenic shock. So there are other conditions, other disease processes that can lead to this condition of respiratory failure. Now, ARDS goes by many different names. It is also known as pump lung, traumatic wet lung, shock lung, progressive pulmonary congestion, and delaying lung. Okay, so it goes by many other names. However, for the most part, we have been transitioning over to ARDS, and this is what we encounter most frequently in our patients' histories when we are reading their charts. And so acute respiratory distress syndrome is characterized by the development of sudden breathlessness within hours to days of an inciting event. And so we'll talk more about that term, inciting event. But there is a very wet lung and in ARDS, and that's why I really do like some of these names, because they're very descriptive of what is actually occurring when somebody has ARDS. They do have a very wet lung. Okay, so that is a very interesting term that we use to describe it as well. ARDS is associated with severe and diffuse injury to the alveolar capillary membrane, which, as we said, are those alveoli, the air sacs, and the very small blood vessels or lung capillaries. And then fluid accumulates in some of the alveoli of the lungs, while some other alveoli collapse. This alveolar damage impedes the exchange of oxygen and carbon dioxide. In other words, it impedes gas exchange, which leads to a reduced concentration of oxygen in the blood. Low levels of oxygen in the blood cause damage to other vital organs of the body, such as the kidneys. This slide will show you the pathophysiology, the changes that are occurring when somebody has ARDS. The capillary membrane becomes damaged. It becomes more permeable. The alveoli fill up with fluid. That's a problem because normally surfactant is secreted there, and now it has been inactivated. So the surfactant that has been secreted becomes inactivated. And then we have the collapse of the alveoli and a resultant congestion or congestive atelectasis. There is also alveolar debris and also the formation of a membrane there. All of this works against gas exchange. You will have one question on the pathophysiology of ARDS, so make sure you do have a little bit of understanding regarding that. ARDS is an acute lung injury, and I don't need you to know too many details, but it is really the resulting injury is because of the inflammatory response. Okay, again, it's very a common idea or concept that really a lot of the injury within our bodies all relates back to inflammation. And so this systemic inflammatory response is what is responsible for causing that acute injury to the lung. We have the damaged capillary membranes. That means the liquid portion of the blood, the plasma, leaks into the interstitial space, okay, into the lung parenchyma itself. We also have damage to the alveolar membrane, and fluid enters into the alveoli themselves. So that fluid inside the alveoli is what's responsible for diluting and inactivating the surfactant. Damage to the surfactant producing cells leads to alveolar collapse with atelectasis. In addition, gas exchange is impaired further because the lungs become less compliant. That means they're more rigid and stiff. They don't expand as they should. Also, we're having this membrane, this hyaline membrane that is forming, and that's also preventing gas exchange from occurring. So we have more than just fluid in the lungs, although that is certainly part of it. But we also have the lungs becoming less compliant. We see fibrotic changes in the lungs. There's less surface area for gas exchange to occur, and the patient becomes hypoxemic. And hypoxemia is also, this is very characteristic, and I think we'll touch on it again, but this statement here, hypoxemia becomes resistant to improvement with supplemental oxygen. So I think in parentheses it would be a good term to write here after supplemental oxygen. In parentheses, write refractory hypoxemia. That means that we can continue to increase the amount of supplemental oxygen that we deliver to the patient, and they will remain with a PaO2 of less than 80, hypoxemic. Okay. In addition, we also have rises in our PaCO2. As gas exchange is impaired, we see a rise in the PaCO2, which is the partial pressure of arterial carbon dioxide. That's the CO2 that's dissolved in the bloodstream. It begins to rise because of the impaired gas exchange. So we have a significant hypoxemia, and we also have a metabolic acidosis that develops. Sepsis and multiple organ system dysfunction can follow. There is a high incidence of death associated with ARDS. They say approximately 200,000 Americans are affected by ARDS each year. And there is no discrimination based on age. Anybody can be affected by ARDS. The mortality rate ranges from 25% to 45%. We see generally a greater incidence in men than women, and a greater incidence of a higher rate of mortality associated with our African American patients. Patients who develop ARDS from sepsis have much poorer outcomes than those who develop ARDS from other causes such as pulmonary infections or trauma. So if I ask you, what is the prognosis for ARDS? Knowing these statistics, I would expect you to say that the prognosis is poor because they don't have a good chance of surviving this. It's pretty much 50-50. So that's a poor prognosis. ARDS typically develops within 12 to 48 hours after the inciting event. Persons developing ARDS are critically ill, often with multisystem organ failure. It is a life-threatening condition. Therefore, hospitalizations are required for prompt management. And certainly mortality rates increase with advancing age of the patient. Although I can say that the outlook of persons with ARDS has improved over the last 20 years, so perhaps there is some increase in the percentage of persons who survive, but it's certainly a life-threatening condition, and it would require immediate prompt management. Okay. As mentioned earlier, ARDS is characterized by the development of a sudden breathlessness within hours to days of the inciting event. Now let's talk about that inciting event. That includes things like trauma, sepsis, that means microorganisms growing in a person's blood, drug overdose, massive transfusion of blood products, acute pancreatitis, or aspiration. And we know that aspiration is fluid entering the lungs, especially stomach contents. Because aspiration is a risk factor for ARDS, taking appropriate measures to prevent aspiration, such as elevation of the head, may prevent some cases of ARDS. So there are many common causes, and I don't expect you to memorize all of the less common causes. However, I do want you to know the most common causes, and there I have highlighted them in purple. Certainly sepsis and any type of trauma, okay? And then we have those commonly occurring things like aspiration of noxious substances. Again, noxious substance refers to the GI contents. Remember, hydrochloric acid, it's an acid. It's going to destroy lung tissue because so the acidity will destroy the lung tissue. And any pneumonia as well. This, just simply having a viral or bacterial pneumonia, can lead to ARDS with the high morbidity and mortality rates. A major concept, an overarching concept really in nursing, is that because of what we know about various disease processes, it allows us to know which of our patients that we are assigned are at risk for different complications and diseases. So it's important that we understand which of our patients are at risk so that we can be monitoring them closely for the signs and symptoms that they may show, indicating that they are developing a condition or a complication. So again, we always want to know the history of our patient so that we kind of are in our head calculating how much risk are they at for developing whatever. Okay, when it comes to ARDS, some of the risk factors that are going to increase their chances of developing ARDS is aspiration. If aspiration is the greatest risk factor and you know that your patient is struggling with aspiration, then we need to be very careful in monitoring and assessing for any changes in his respiratory system that might indicate that he's developing ARDS. Also, smoking. If your patient's a smoker, they're at increased risk of developing ARDS. And certainly if your patient is immunocompromised. And we have lots of patients that are immunocompromised. Remember, this is not isolated to our AIDS patients. So immunocompromised can be a transplant patient, any patient that is on anti-rejection medications, patients that are on corticosteroids, perhaps because they have chronic bronchitis. All these patients are immunocompromised. Sometimes their age alone puts them in this category. The older adult and the infant and the child who hasn't developed a strong immune system yet. So we want to prevent the development of ARDS by carefully looking at our patient's risk factors for developing it and then intervening to prevent it from developing if we at all possibly can. As we said, the signs and symptoms are going to show rather quickly in 24 to 48 hours after that inciting or initial event or insult. Okay, they can call it an inciting event or an initial insult, but that could be trauma or it could be sepsis. That's when we need to start looking for it. We can also use lab data to help us identify changes in the patient's pulmonary status. And by that, we especially mean our arterial blood gases. We can also do chest x-rays. And we have to assess for those early signs that they're having difficulty breathing. And we can do that by counting their respiratory rate for 1 full minute and observe if the rate is going up or have they become tachypnic. Remember that 30 breaths per minute, although very subtle change, we have to really look because we can't just observe that by glancing at our patient. But if they are truly breathing 30 breaths per minute at rest, that's a red flag, folks. Okay, that means that they are struggling to get their body perfused and oxygenation occurring. Okay, so that's an indication. You need to look at their respiratory rate. It's going to be our first clue many times that our patients are going to undergo an acute disease process. We say that the signs and symptoms of ARDS are often insidious. That means we don't see it. It's like they sneak up on us. all of a sudden it's like, oh my goodness, my patient is having difficulty breathing. Okay, so that's why it really takes careful assessment, looking for those subtle changes. Okay, so some of the symptoms of ARDS include anxiety, agitation, fever. It's only later that the symptoms worsen. Okay, so we have to observe and assess respiratory rate. Look for retractions of the intercostal muscles. Look for any use of accessory muscles in that patient. Remember, the patient will become tachypnic. They will have a very fast respiratory rate as their demand for oxygen increases because gas exchange is impaired. If you auscultate the lungs, you may hear rales or rhonchi. The chest X-ray shows significant interstitial changes and patchy infiltrates. We can use the pulse oximeter as well to give us an oxygen saturation, and an even better assessment of their acid-base status would be shown with the arterial blood gas levels. Okay, when you do an ABG, it's going to show that characteristic refractory hypoxemia. So you may want to highlight that in your notes as well. What we mean by refractory hypoxemia, even when the patient is ventilated, we can continue to go up on the supplemental oxygen that we administer, and it will not improve the PaO2 of the blood. It will still be less than 80%. Okay? Despite our best efforts, we can give them 100% oxygen. It doesn't matter. They still will not have a PaO2 of, they will not have it greater than 80. Okay. We also, as I said earlier, they start to become anxious and agitated. And then as it progresses, the symptoms may lead to confusion and lethargy, which are more serious changes in the level of consciousness, reflecting the fact that they are not able to meet the body's demand for oxygen and the brain, right? Okay, so here we are reviewing some of those important symptoms of ARDS. Remember, again, they kind of sneak up on you. They're often insidious. They begin to have difficulty in breathing, and their breathing is faster. They may be tachypnic. They may develop a cough. They may become restless. Remember restlessness, what it refers to. That's the first sign that we're not getting enough perfusion to the brain. Okay, that's your first change in level of consciousness. We have crackles, rales, and rhonchi in the lungs, so you should be able to pick up on those adventitious breath sounds. We'll see different things depending where we are in the stages, not really stages, but in the course of ARDS. It may vary depending exactly where we are, but initially the patient is going to be in a respiratory alkalosis. In response to that mild hypoxemia in the beginning, the patient begins to breathe faster. They're breathing faster and basically blowing off the CO2, the acid component. So they go into a respiratory alkalosis. But remember, because the lungs respond within minutes of these imbalances when they occur, it's later, it takes hours, even days, for the kidneys to start coming into play to help compensate this imbalance of respiratory alkalosis. And their goal then would be to put the patient's body into a metabolic acidosis to compensate for that respiratory alkalosis. Then we also have chest x-rays, and we're going to see a picture of that, and we're going to see that diffuse infiltrate, meaning we have fluid in the lungs all throughout the lung fields. That's what we mean by diffuse. This patient must be intubated and ventilated if they have any hopes of surviving. The chest x-ray here shows the presence of fluid in the lungs. You see all of that whiteness spread throughout the lung fields, where normally it would be very dark with healthy, clear lungs. Radiologists refer to this as a diffuse ground glass appearance. So when you are reading your patient's chest x-ray findings and you see the terminology ground glass appearance, that is your indication that your patient has ARDS. Let's talk about some of the diagnostic tests that are going to be used for a patient who has ARDS. Certainly we're going to be doing plenty of arterial blood gas analyses. And that, of course, will provide us with lots of information, but it will, more importantly, give us a very accurate indication of the oxygen levels, dissolved oxygen in the arterial bloodstream. Okay. So definitely we'll be doing ABGs on this patient. We'll be doing chest x-rays, perhaps a chest CAT scan, but frequently, more often, the chest x-ray to determine if there's fluid in the lungs. Okay. The CBC will be done. Remember, some of the inciting events for this, one of the most common is sepsis. So we want to do a CBC. We want to look and see if the white blood cell count is elevated. We'll do blood chemistries. In that vein alone, we also need to do our markers for sepsis in chemistry. So we'll look at those as well. And we will draw blood cultures because we may need to identify the organism that is causing the pneumonia, for example, and then we will know what has led to ARDS. In addition, we're going to do sputum cultures on these patients. And this patient is going to be in the ICU and is going to be intubated. So this is the apparatus that you see in this diagram. It's called the Lukey trap. Lukey trap. And this allows us to suction a sputum specimen from our patient's lungs. Okay, and so we can advance a sterile catheter down the trachea and apply low intermittent pressures to remove a specimen of sputum. And this can be done in a very sterile manner simply by connecting the catheter either to suction or turning it back around and applying it to the nozzle there on the specimen jar itself. So then we can simply detach it and take it to have it sent to the lab. And we have a nice sterile specimen of sputum so we can see if we can grow out an organism that is causing the pneumonia and the ARDS that it has led to. So treatment for the patient with ARDS. Persons with ARDS are hospitalized and require treatment in an intensive care unit. Because ARDS is an urgent medical condition that typically follows a significant illness or injury, the patient is usually already hospitalized when ARDS develops. There is no specific therapy for ARDS. Treatment is primarily supportive using mechanical ventilation and respirator, as well as supplemental oxygen. But the mechanical ventilator will allow us to support the patient's respiratory function while we are trying to identify the underlying cause of the ARDS and treat it. Okay? But endotracheal tube intubation is the mainstay of ARDS management. It's rarely possible to maintain adequate oxygenation with supplemental oxygen therapy alone. Okay, so we have to have this patient intubated. Now, I'm also going to tell you shortly, we're going to be learning about mechanical ventilation. And on the ventilator, there's a mode called PEEP, and we'll be talking about what PEEP represents. And this is going to be the real key to getting better outcomes and improving oxygenation for our patient who has ARDS. Because remember, we said they have a refractory hypoxemia. It is this function here called PEEP that allows us to combat that issue and improve their oxygenation. Now, certainly part of the treatment involves administering intravenous fluids given to provide nutrition, to prevent dehydration. But again, we have to remember to carefully monitor the patient to prevent too much fluid from accumulating in the lungs, which would be a pulmonary edema. Okay? And because infection is often the underlying cause of ARDS, we're also going to be administering the appropriate antibiotic therapy as well. But this is very key in the treatment of ARDS patients is positioning. It's probably the only time you're going to hear this type of positioning used in the hospital. Prone positioning rather than supine. You know that most patients in the hospital are in a supine position. However, a supine position puts pressure on the lungs of an ARDS patient. Okay? And it puts pressure on the lungs because of the weight of the heart and the mediastinum, which are the large vessels in the body in that area of the chest. Because when you're laying flat and supine, the heart and the chest and mediastinum put pressure on the lungs, and that is not beneficial to a patient who's already having problems with gas exchange. Now, if we flip the patient over, put them in a prone position, that relieves that pressure on the lungs. Okay, they are able to expand easier. And remember, we already have a problem with compliance of the lungs. So we want to relieve that pressure so that the lungs can expand and hopefully improve surface area for gas exchange. So this positioning, prone positioning, is reserved for patients who have refractory hypoxemia, which is exactly the hallmark symptom of our patients who have ARDS. Let's talk a little bit in more detail about the medications that we're going to use for our patients with ARDS. Certainly antibiotics will be needed to treat the infection, but we can also use anti-inflammatory drugs such as corticosteroids to reduce inflammation in the lungs, especially in the late phase of ARDS or sometimes if the person is in septic shock. Another thing that we want to do is to use diuretics to help eliminate fluid from the lungs. We may have to use drugs to counteract low blood pressure. Again, those are vasoactive drugs. Okay, that they will help to raise the patient's blood pressure, especially if they are in a state of shock. We also have anti-anxiety drugs to relieve anxiety. And inhaled drugs are administered by respiratory therapists to open up the airways, and those would be our bronchodilators as well. Those actions, interventions help to improve the patient's ability to have gas exchange occur. We don't want anything that's going to hinder that. Survivors of ARDS may recover normal lung function. However, some of them may have residual lung impairment or persistent muscle weakness. Typically, the lung dysfunction is mild, but ARDS can lead to severe lung damage and a reduced health-related quality of life. Severe disease and prolonged duration of mechanical ventilation are predictors of persistent abnormalities in lung function. This is a review slide for ARDS. You see in the right-hand corner, we have a list of all the causes that can lead to ARDS. Again, on the top of that list, well, as the top and bottom, trauma and sepsis. We need to remember those as the two common causes. And other causes would be aspiration, even shock, remember. So we've already learned about shock, but shock can absolutely lead to ARDS in these patients, and multiple organ failure. And then we also see here the signs and symptoms of ARDS. Again, why it's insidious is because tachypnea. It's really hard to detect that and pick up on it if you're not counting breaths per minute. So tachypnea, dyspnea, muscle retractions, hypoxia, when you're not getting your tissues perfused, the patient starts to demonstrate signs and symptoms of hypoxia, including restlessness and agitation. The heart begins to beat faster because the body is not getting enough oxygen to meet the demands. And we've already said, as the pathophysiology of ARDS involves a decreased pulmonary compliance. Now, ABG results, we see a hypoxemia. That's what the arrow and the partial pressure of dissolved oxygen in the arterial blood is less than 80. And it goes down as the PaO2 gets lower and lower. The patient is going to demonstrate more dyspnea. Now remember, I would write that word again, refractory hypoxemia, under this picture, because it's in parentheses. It says the patient's not getting better even with an increase in FiO2. Now that may be a new acronym for you. What does FiO2 mean? Well, when we talk about mechanical ventilators, there's going to be a function on that machine that says FiO2, and it stands for the fraction of inspired oxygen, okay, in the air that you are giving that patient who is ventilated. So the FiO2 is the fraction of inspired oxygen. Okay, and we see the X-ray there, and the lungs are all whited out because there is a diffuse infiltrate, and the patient should be intubated. Okay.